Evening, everyone. Welcome to Peer-to-Peer Academy. We're doing a webinar tonight on thinking outside the box, mixing and matching with the LAL, the LAL Plus, this awesome platform we have, combining it with different technologies too. So tonight I'm joined by two of my good buddies, Eric Fazio and Brian Szabo out of Tampa Bay, Newsom Eye Care. So why don't you guys introduce yourself? Brian, take it off.
Yeah, thanks so much, Nick. Thanks for so much for having us and asking us to be on this chat and talk about these really cool technologies. My name's, a lot of you don't know, I'm Dr. Brian Szabo. I'm a cataract refractive LASIK surgeon here in the Tampa Bay area. Actually did my fellowship with Dr. Hunter Newsom purely to study the light adjustable lens. So that's kind of like kind of how I got involved in everything. And afterwards, he asked me to stay. So I'm in my third year of practice and really loving life here in Tampa Bay.
How about you, Eric?
Good. Yeah, my name's Eric Fazio. I'm a old guy, so I won't tell you when I graduated, but I came out of Waterloo. So yes, I am originally Canadian. Did a residency at PCO, so that was fun. And I never practiced one day in Canada, so I went straight to work for an ophthalmologist in Tampa. We prefer to call it Champa Bay, Nick, by the way. So
I like
gonna
it.
correct it right there. But I've been working for Dr. Newsom for 15 years. I am the medical director here. Kind of fun side fact. We do train residents here, which is fun. I'm the residency director here. I train 3 a year, teaching him about the LEL, which is cool. Szabo was a fellow of Dr. Newsom's, which you already mentioned, but he probably did 1,000 adjustments in his fellowship. I was, thankfully, riding on Dr. Newsom's coattails, part of the original study back in 2012. That started a long time ago. That's crazy to think that was 13 years ago. Kind of nuts. And then when it got submitted in 2017, I was a co-investigator, so that was fun. We waited for it to get approved. In 2020, we just kind of took off. So we do thousands a year. We're high volume. We did do the LAL Plus study, one of the 10 that was chosen for that too. So we know a lot about it. I know you do, Nick. Thank you
Yeah.
again. You're high volume OG yourself, and we thank you for what you do and the education you bring.
Hey, appreciate it, man. So Tampa Bay, is that a Tampa Bay Bucks thing?
It is. No,
Uh,
well,
And lightning.
in the
Yeah.
Lightning.
and the
Lightning.
Lightning.
So they just got
Awesome.
eliminated, so we won't
We won't
talk
talk
too
about
much
it. We,
about that.
we won't
Yeah.
talk about it. So yeah, I mean, we in Milwaukee, full disclosure, I'm not a Wisconsin guy. I'm a Michigan guy, so I'm a Detroit guy. So go Lions! You guys took it to us last year. I'll give you that one. But yeah, we do here in Milwaukee. We opened our clinic in 2020. We were early adopters of the LAL2, and we're part of the LAL Plus study. So we do, we've done well over 1,500 cases at this point, getting comfortable with it. So tonight, the LAL and the LAL Plus, arguably they're more similar than they are dissimilar. There's a lot of similarities between the two, but there's also a lot of differences. And there's a lot of room to expand the platform to mix and match and design treatments to even more customizability, to even more customizable outcomes for our patients. So I mean, Brian, I mean, we were talking a little bit earlier. You did a little bit of an in-house study looking at your outcomes. I think you had some slides you want to share.
Yeah. So I'll just kind of preface it a little bit, Nick, with,
Hmm.
when we were part of that 10 practice study across the nation where we were implanting the LAL plus lens for the first time and seeing the results, we noticed between our practice, your practice, Vance Thompson's practice, there wasn't much of a big difference in outcomes, okay, at first. So we thought, oh, the LAL plus are very, very similar. They can be used in very similar ways. Maybe the patients are getting better vision right after surgery because of the depth of focus in the LAL plus. But then we started to use it more in practice. And like Eric said, we do probably at least 1,000 of these a year, 1,000 LAL implants a year. And we started to notice some differences in the LAL plus model and the regular LAL. And the question was, the LAL plus, we noticed when you do your near adjustments, you got to go slow. You can't go as really maybe as fast as you would like the LAL. The LAL, our first target for a near target is a -75. Then we jump up to a -125, and then we kind of keep pushing based on the patient. But really, with the LAL plus, our first adjustment is really plano, and then we go a -50. So you really have to kind of slow down we noticed with the LAL plus, or that patient could fall right off a cliff with their distance vision if you have a near target. So really, our in-house study came from the fact that we noticed that very quickly because we implant so many of them. And then the question was, can I use this technology to keep the eyes as similar as possible? You know, with a regular LAL, you know, one eye's a plano or plus 25 target, and the other eye, you're shooting at a myopic target to try to get that, you know, that mini mono, that depth of focus through mini mono optics. So we thought, you know, some of the problems we saw with that is, you know, patients that were emmetropes and -2s were really noticing the differences in the eyes. So our question was, can we use the LAL plus to kind of keep the eyes, put the LAL plus in a non-dominant eye and kind of keep the eyes as similar as possible, hoping for maybe a plus 25 plano target in a dominant eye with a regular LAL, and then hopefully getting like a plano to -50 target endpoint with an LAL plus. And that's kind of how this study was born. So I'll show you guys some slides we have up to this date from our in-house study. Okay, can you everybody see this?
Mm-hmm.
Okay. So our targeting strategy, so this is as of early April, okay? So the strategy basically, like I said, is in a dominant eye, we're using an LAL. So we want the best distance possible. So obviously we're going to achieve that with a monofocal LAL, okay? Our target is always a plus 0.25 target to start with in that dominant eye. So we always, this is our Newsom eye strategy, dominant eye, the LAL, we're doing a plus 0.25, okay? In the non-dominant eye, the first adjustment is always plano, okay? And the reason is, if you look at this graph I'm showing right here, so the red boxes are our dominant eye. So obviously everybody's a plus 0.25, okay? That's our target. But look at how many planos we locked in because they got J1 at plano with the LAL plus, okay?
Mm-hmm.
So out of the 20 eyes we did, about 5 of them never needed a myopic target because immediately after a plus 25 in the dominant and a plano target in their non-dominant LAL plus eye, they were 2015 J1, okay? Without even delivering any myopia to that LAL plus eye. So our first adjustment in the reading eye is always plano. And then we move in half diopters, okay? So as you go down here, you guys can see my mouse okay?
Yep.
Mm-hmm.
So right here is the bulk of where our patients end up, is at a -5, okay? This is a minus 0.5, okay? So that is where most of our patients end up in that LAL plus eye. So you're getting plano target lock-ins, you're getting a -50 lock-in, and they're J1 happy patients. And that was the whole goal of our little study, in-house study, you know, was to keep the eyes as similar as possible. And as you can see, it's kind of paying off, okay? And just going for our first 40 eyes, 100% of the patients OU are 20/20 uncorrected distance vision, and 70% of them actually reach that better than perfect mark at about 70% 2015, okay? These are outstanding distance results. And then secondly, even more impressive are the uncorrected near visions we have with giving such a minor little bit of myopia treatment. So 95% of these patients we treat with this kind of method we're using are J1 uncorrected near vision. I mean, guys, J2 is what we're all after. J2 is functional reading vision. And I think that gets lost in translation a little bit because we can see how this technology can be pushed to J1 plus. But if you're J1, you are reading your phone, you are reading a menu, you're reading a book, okay? And 50% of the patients we did actually got to J1 plus with our strategy as well. So J1 is a total hands down win. And that's what we're kind of seeing with our results so far in 40 eyes only so far. Right now we got about closer to around 70 eyes enrolled, which we'll be presenting this data at the Academy come up in Orlando here in the fall.
That's super impressive. You know, I think you make it a good point about being like plus a quarter, especially with the LAL plus. That's not a bad strategy at all. One thing to remember too, I mean, when you're refracting, I'm assuming you guys aren't using 20-foot rooms. Nobody has 20-foot rooms anymore. Everybody's got 10-foot rooms and then there's mirrors, right? Or do you have 20-foot rooms?
So what we did there, Nick, which was, I'll just
Hmm.
jump in there a bit. We kind of went a little overboard. So we designed 4 rooms exactly the same length,
Okay.
specifically for our LAL patients, and
Interesting.
then a lounge. So we put them at 15 feet with the same exact charts, the same exact everything, literally duplicated everything exactly the
Cool.
same.
Cool.
Loaded them with trial lenses, big rooms, comfortable rooms. And then we kind of have a little lounge, which we have a little dark room as well for them to dilate in. So that's
Cool.
kind of what we do at Newsom. But yeah, it's still a projected high contrast screen, no non-mirrored, non-mirrored.
Awesome. So, I mean, most people probably watching this in our clinic, especially too. I mean, we've got short rooms. And so, if you're refracting to plano, optically in the real world,
Yeah.
plano is about minus a quarter. And so, you're kind of giving up a little bit. So, ideally, especially with my LAL plus, because of the a little bit asphericity of the lens, if you end up a little hyperopic, it's a good thing. You're not really giving anything up that way. And you're still going to get the benefit of the depth of focus. So you're plus a quarter, if it's plano to plus a quarter, that's a perfectly ideal outcome for a distance set LAL plus eye, but you're not going to have any compromise at distance. The difference between the LAL and the LAL plus, if you really look at the data and you're looking at if you're looking at the defocus curves, you can just take that defocus curve with the LAL plus and just shift it a little more towards the hyperopic. You're going to maintain perfect visual acuity. And anecdotally, I mean, I haven't seen any difference between the two, at distance, but you are gaining a lot up close. And I think, Brian, you mentioned the point about not having to give as much up in the non-dominant eye. That's exactly what we use it for. We're ending up at about. So what's your average target then? You said -1 for your LAL plus?
No, I would say our average target is that minus 50.
Okay.
Okay. So yeah, so I'm shooting minus 50. That's generally where you see most of these patients kind of ending up is the minus 50 area. Minus 75 a little bit, but I mean that's fantastic in terms of, the comparison
Mhm.
between eyes. Between
Yeah.
like the disparity. I mean, because you've noticed when you push a patient, you keep pushing them more reading, they want more reading, they want to get to
Hmm.
J1 plus. They start to notice that shadowing a little bit. They start to notice the differences, or they're really comparing eyes, and they've never done that before. You know what I mean? So you want to keep the eyes with this optical pattern as similar as possible, especially like I said, in the population of the emotrope and the -2. Okay.
Hmm.
A -6 or a +2, you're going to knock it out of the park with these patients. A monovision LAL patient, you're going to knock it out of the park, any post refractive. But this strategy with the dominant regular LAL, the non-dominant LAL plus, is really made for the virgin cornea or the maybe earlier cataract refractive lens exchange patient.
That's awesome. I think, that's where we use it too. So if we've looked at our data and kind of how often we've used the LAL plus versus the LAL, and it is about 50-50 in our practice. We do the LAL plus in those virgin corneas, the corneas that a cornea that you would put in a depth of focus or you would consider putting in a multifocal,
Exactly.
20/20 capable eyes. So that's how we use the LAL plus. Now, how do you guys determine eye dominance? Everybody's got a different test on how they do that. How do you do that?
Uh, that can get to be a big stickler. I mean,
Sure.
I think you can look and probably find pretty good studies, because it's been come up as an issue throughout, eternity in refractive cataract surgery or LASIK or what have you.
Uh-huh.
I do the good old
Yeah.
2 feet center. We have this little logo, Newsom Eye logo that we put at the end of all rooms, and I just have them center it. And I'm watching really carefully, make sure they do it correctly. That's what I do. That's what I do.
So that's also what I do in the consult as well. And then if push comes to shove, we are in Florida. Nick, a
Mhm.
lot of people have guns.
Yeah.
Yeah, that's
Um,
the other thing.
so
The
I
same
was gonna
patients that we have up in Wisconsin.
yes, yes. So and nothing, we're not gonna get political on this
No,
show,
don't get political.
but but you always ask me, what's your shooting eye? And
Yeah,
everybody always
I do
knows
that
it down
too.
here.
I do
Yeah,
that
it's
too.
just a shorthand,
How do you
obviously.
line up a gun? Do you ever shot a gun?
Yeah.
Yeah,
I do
that's
that
my
for all
stick.
our patients too, and it's always funny when I'll just say that kind of out of habit. And I had the other day like an 86-year-old lady, like a little old lady weighed like 90 pounds, and she's just like, "Oh yeah, I shoot with my right."
Yeah.
Okay,
Like,
all right,
holy crap. Wow.
okay.
Hopefully
How's
I
the
don't mess
shooting?
this surgery up for you. Yeah.
Wait till you have the patient pull a gun out of their purse. I had
Yeah.
Yeah,
to do that.
that
I had
hasn't
one do
happened
that
yet,
to me. I'm
but
like, what are you doing? Stop.
that's how I do it too. And Eric, I mean
Oh
the little
God.
circle thing, that's a lot of times how I do that as well. A
Yeah.
question just came in, and a reminder to everybody watching, questions are awesome. We want to keep this interactive, so go ahead and type it into the chat box in the bottom, and we'll get to all the questions. First question, the study that you just talked about, your little in-house study, was it LAL in the dominant eye, LAL plus in the non-dominant, or was it LAL plus in both?
It was a mixing. So it was all those patients were an LAL regular in their dominant eye for
Okay.
distance, and it was an LAL plus in the non-dominant eye.
Okay. Second question, how often does it come up where patients' eye dominant switches? Do you get that?
So yeah, actually, I had to throw 2 patients out of the study just because they switched the eye dominance.
Okay.
Okay. And with those 2 patients, though, the outcome OU was still 2015 J1, which is kind of hilarious how that happened. Which is great for us. You know, what I mean, now is that due to the lens? Is that due to a little bit of depth of focus and the other eye as well? With the regular LAL. So that's that does happen because you do sometimes. Faz, you can comment more to this. The dominant switch after cataract surgery, it does happen.
It does, because that's sometimes when you see that bad cataract in one eye and the patient just kind of shifts that dominance and you're doing the test and it's just wrong. They just don't see well. What are you going to do? The cool thing with the LEL, like, we always try to target, hyperopic and go in one direction. I know there's been some thoughts on that, but we've always been successful with that technique. We can dig deeper into that if you'd like, because there's been some changes of thought process, I think, a little bit. But when you do that, you can retest dominance when both eyes have the cataracts out and kind of try to drive it that way as well. One of the other comments I want to make is you guys are making great points, but I try to dumb it down. And for some of the ODs in the audience, anyways, the way I try to think of LAL plus and LAL is kind of like a near-centered biofinity contact lens of low power.
Hmm.
So it's going to do well at near. It's not perfect at near, but it's not killing your distance. And to your point, Nick, the way that it achieves power is just kind of slow power change gradient to the center. It's very gentle, so it really preserves a lot of distance vision. But let's be honest, too, it's also an extended depth of focus lens, period. So there are going to be those patients when you have that selection process, which again, we can drive into, that you got to be careful that if you put 2 of those in and you have not properly evaluated those patients' needs, you can get in trouble there. You can get in trouble with distance vision. Not often, we do a lot of bilateral pluses, to be honest. We again can dive into that, but I just want to kind of make that analogy for ODs that do kind of modified multifocal fits, where you do like a multifocal in one eye, but the
Hmm.
person's really picky at distance, so you put a regular monofocal in the other eye. That's kind of the way I try to explain it to other ODs so they're comfortable with it. It's very important to be comfortable with what you're doing, to be able to be that expert in the room and to talk to patients and get them comfortable.
That's a good point. I mean, so full disclosure too, we don't do a lot of mixing matching in Milwaukee because I've observed that, and this is kind of the beauty of this platform is we can disagree and both be right. The
Right.
LAL and the LAL plus, I mean, the eye dominance does flip maybe 10% of the time. You've got
Yeah.
patients who are they're ambidextrous. They can throw with their left
Yep.
hand and their right hand. And sometimes they have no idea, their right eye might be the better of the seeing eyes because their cataract in the left eye is worse, but it turns out
Right.
that their left eye is actually their dominant. And so I don't always love committing, although we have done it and have done very well with it. But that's the beauty of having the LAL and the LAL plus. So if I'm sitting pre-op and I'm not convinced that a patient is a good candidate for the LAL plus, or I'm not convinced that we can do, their eye dominance is really true, we may stick
Mhm.
with just a straight LAL, which gives us probably
Mhm. Yeah.
more flexibility. We may
Sure.
give up a little bit of the reading ability there, but we're not going to put the patient as we're not going to put them in jeopardy of compromised distance.
Right. Right.
So there is
And,
there is
Yeah.
several ways to look at it. Let's
and it
talk.
is.
Let's
There
get
is.
in.
Oh,
Yeah,
go ahead,
let's
Nick. Go ahead.
Go ahead, Nick.
let's get into
Yeah.
the nitty gritty. I mean, what
Yeah.
what would make a patient a candidate for an LAL plus versus an LAL versus a mix and match? How do you determine who is who?
Yeah, so I mean, if we're strictly talking mix and match, so talking mixing,
Mhm.
so I'm, in Florida here, I'm seeing a lot of like the age range of, mid to late 50s to, 60s, a little bit earlier of a cataract. People in Florida, they're retired, they're playing a lot of pickleball and golf and tennis. They're very active cataract, age patients.
Mhm.
So therefore, in patients like that, that's who I'm kind of selecting. Obviously, always virgin corneas with an LAL plus. We are
Mhm.
not putting LAL pluses in any. I saw a question kind of come up in the chat. We are not putting any LAL pluses in any post-refractive eyes. So just like you said, Nick, we're treating it just like a multifocal or
Mhm.
an extended depth of focus. Okay. Even if the Ks look good on topos, I am going regular LAL all day in post-refractive. But in those virgin corneas, where I'm studying a reading expectation of phone vision, and they're a very active individual, I'm mixing and matching. Okay. Because I'm loving where I'm kind of ending up, not taking the eyes apart from each other. Now, if I have virgin corneas and they're an avid reader and they're a CPA, they're a lawyer and they're still working and they're still doing everything, I'm going back bilateral pluses to try to get as much depth of focus as possible to get
Mhm.
them the best reading vision with an LAL. With a virgin cornea, LAL pluses OU all day. Okay. Obviously, any monovision patient, any post-refractive patient, we are still fully LAL regular all day long. That's how I approach it. I approach it more, are you post-refractive and what are your hobbies?
Yeah, I think that's fair. One thing I always like to kind of reinforce too, with the straight LAL, you have the ability to add depth of focus
Right.
during the light
You
treatments,
still have
right?
EDOF.
Yep. Yep.
Which, use that cautiously. Again, you
Mhm.
wouldn't want to do that in somebody who does have an irregular cornea, but just to
Right.
recap, it's the first treatment you got to move in the myopic
Yeah.
direction to a target of -50 or more, and both
Oh yeah,
meridians have to steepen.
And your delta's got to be 0.5. Right.
Yeah, so if you're
definitely.
doing those, if you're meeting those thresholds, you're going to get a little bit of a bump. It's
Mhm.
not quite as much as the asphericity or the depth of focus as the LEL plus, but it's something. So you still do
Yeah.
have ability to
Oh
do
yeah.
that, and just
Yeah.
be
Big
aware
time.
that you're doing that. I
Yep.
talk to
Yep.
docs all the time, and they're like, "Well, what happened here?" I'm like, "Oh, well, X, Y, and Z. You met all those three criteria. You
Yep.
did that. You should have done that." In
You shouldn't
hindsight,
deliver that negative essay. Yeah, you should look at that
yeah,
topo a little bit more, pay attention to that Q value a little bit more. Yeah. Yep.
exactly. So careful with that. Um, so I think both of these, my favorite patients are golfers. Brian,
Yep.
you golf, I know. Eric, you golf? These
Yes.
are my favorite because they're the
I'm a
guys.
lefty, so it's a rough time out there.
Just
Mhm.
switch hands. Go try right.
Yeah, I
Do
can't
better.
do it. And I'm not Phil Mickelson, so yeah,
Those are my favorite patients though, because those are the ones who,
yeah,
their demands are at a distance, right? They want to see their ball.
yeah,
They want to see their scorecard or their tracker or their watch,
Mhm.
and they're naturally competitive. So it ends up being a kind of a pissing match on the tee box. I can see the ball. Can you see the ball?
Right. Right.
And that's how we've got a lot of our patients. Wisconsin's got a lot of good golf, and you guys, I know,
Yep.
obviously have a lot of good golf down there. So those are my favorite.
Yep.
But the plus does well.
yep,
Do you guys ever consider pupil size in your LAL plus versus LAL?
So we did Foz, what, maybe 2, 3 years ago, we were
yeah.
really
We were
measuring
very
pupils.
militant
We were
about
very
that. Yeah,
diligent with it. But then, as we kept moving along, we kept putting in smaller pupils. And right now, to be quite frank with you, at New Samai, I mean, pupil size, we don't consider it much of an issue. You know what I mean? Obviously, if you're a pinpoint pupil, big Flomax or and it's just not going to work. We stay away from it.
Hmm.
But generally, I mean,
yeah,
we're not really measuring pupil size much anymore, Foz,
yeah.
correct?
Well, yeah, I'm a process guy. I agree with Brian, but he knows me. So getting back to again your original question and then hitting on that. For us, Nick, we do a very formal lens questionnaire for candidacy, and then we do a thorough testing evaluation. I think again we've kind of changed our thought process on that as well. We test them as much as we do any patient because we want to target them well. And we want to look at that surface to kind of determine a bit of candidacy and where's that cornea? Is it irregular? Did they forget they had refractive surgery? But one of the things I am looking at a little bit is that pupil, maybe a little more than the surgeons. And if I do see a crappy pupil, like, the poor dilator, Flomax, all those things, definitely, I'm going with the regular LAL. I avoid the plus in those cases. Yeah.
would there be a reason to think, I mean, as somebody who's not a great dilator, but they dilate enough, if they have a smaller pupil, you're going to catch more of that aspheric zone with the LAL plus, so their near vision theoretically should be better, right?
It is, but
I think so.
what you're worried about, I mean, you can do it in the non-dominant, and as long as you have a patient that wants near vision, I guess.
Hmm.
So that again gets back to the questionnaire and just how do you talk to your patient? Because you have that patient that really wants, like your golfer, they could get a bit bothered by that disparity, or they can get a bit of a doubling effect I've noticed on occasion, or an embossed kind of 3D effect you'll hear. They typically neuroadapt to that, and you don't typically hear that after 3 months. That's the good news. It's pretty forgiving. That's just something that I've noticed, and that's getting a little nitty-gritty. I don't know if I would say that's always going to happen. That's just
Hmm.
something I tend to avoid and stick with the regular optic and just play it safe. It is playing it a bit safe, but that's what we
Yeah.
do.
And I know just off the cuff, Nick, 'cause you told me to be off the cuff for this meeting.
Yeah.
I'm not really looking at. I'm putting this in regardless of pupil size. I know the outcomes we get. I know, I do all my own adjustments. I know how to, even if I don't see a little bit of a haptic, I know how to focus the LDD treatment. Just you look at the iris, get in focus,
Yeah.
push a little bit forward. You know what I mean? So get the iris out of focus.
Yeah, and
And
to be
we,
clear, yeah, I don't exclude patients, of
yeah,
course. I just don't pick the plus sometimes in those patients.
if they're
We still do the
extremes, for
LAL.
sure.
Still do the
Yeah,
LAL. Yeah.
yeah,
Yeah.
Yeah, I don't focus too much on pupil size anymore. I mean, in the early days we did, and of
Not at
course the
all.
label says that you do, but in our
yep,
experience, we're allowed to be off label here, and you
right.
know we keep it on the DL. Don't tell the cops or anything. But
Yeah,
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 pupil size, you can get by with a lot as long as you're
you
focused
can.
on the correct Z axis. It's
yep,
ideal to have both haptics. You may have to do a third treatment, or a third lock-in just in case,
yep,
because the last thing you would want is to get a partial lock, have your patient go outside and have some of those macromers, especially down by you guys where the
sure,
sun is a little bit more intense.
sure.
So
And
doing a third
honestly, you
lock in
really
those
don't
cases.
see that too much anymore since that active shield component's been built into the LAL lens. You know what I
Right.
mean? So
Yeah.
that's happening less and less. I mean, I in my 3 years of practice have never seen that happen. You know what I mean? So
Mhm.
Yeah.
coming in back in after like a lock two with that hockey puck look to the lens, we just don't. I've never seen it with my own two eyes, which is great,
Uh,
which is a testament to the active shield component. That
yeah,
Yeah.
I
the
So
never
when I
have
was
either. Yeah.
when I was doing the studies, Szabo was still in diapers. So when I was there, we full disclosure, no BS talk. I saw PPP about 3 times.
Okay.
Uh, Most of them were admitted. They said, "Hey, I didn't wear my glasses and I went to the beach all weekend." Did really egregious things. Since Active Shield, I've seen nothing, nothing. And I know there's compliance issues. There's always going to be compliance issues, especially with our volume. Not a one.
It's just like, your glaucoma patients. Do they actually take their drops like they're supposed to? Of course they don't. Or it's just like me
right.
with my dentist. Do I floss my teeth every day? Of course I do. Wow.
Mhm.
Well, I got a funny story there. So we did recently, we did an A-list actor. I was telling you this earlier. Won't mention any names, but I just had adjusted him yesterday. I did his first lock. So he gets one treatment. And the first thing I see him on Instagram is doing the opening pitch for like Washington, with no glasses on, going like, rah, and like
Yeah.
staring into the sun. I'm like, dude, what are you doing? So I lit him up on that. And he's like, yeah, I just couldn't do it. I didn't want to wear those things out there. I'm like, oh my
Yeah.
God.
Oh man.
And I have a follow-up story with that. So one
And
of
he
the
was
guys,
fine. He was
yeah,
fine.
yeah, he was fine, right? So one of the guys I
Oh, yeah.
did actually invited me out on the golf course with him while I was adjusting him. And I did the first adjustment, and he says, "Hey, Brian, come with me to the golf course. We're gonna go. I'm gonna show you what I'm looking at." And I freaking walk up to the driving range, and this guy doesn't have his glasses on, just smiling at me. I can see great. I'm like, I'm doing so good. I'm like,
Okay.
dude, we just played 18 holes, and you didn't wear your glasses. What are you doing to me? You know?
Yeah,
God.
it's bad.
But he turned out fine. Everything's fine.
Everything.
So,
Yeah, I've never seen it before. I've
Everything.
read about it, and I know my patients. We do tell them. What we tell them in our office is wear them when you're outdoors during daylight hours. We want you to, and most of our patients are, they're naturally type A. They're a little bit neurotic. So they're like, oh my God, okay.
oh yeah, I think
They
it's
don't have to have
yeah,
them on indoors.
right.
I've never seen a problem. The Active Shield is really, really robust. There is a
Yep.
thought that it wears off. So I get the questions sometimes where
Yeah.
can we delay treatments for 6 to 12 months? And
Mhm.
I wouldn't do that because at some point that active shield is gonna wear off and then you're gonna have
Right.
problems. So we always try to get through the
Agree.
treatments,
Agree
within
with
Right.
a
What would you
certain.
say, Nick? I mean, we at Newsomaya, we say 6 months. Within 6 months, we need to finish
Yeah,
as
yeah,
quickly
that's
as possible. We hope, but as long as 6 months.
yeah, we say 6 to 8 weeks is on average for a healthy, normal
Right.
routine. Somebody who's like an RKI or just having a really rough time, or 6 months is kind of our at
Yeah.
that point we want to get done.
Right. And then
So
the biggest problem in Florida, we have the snowbirds that come back
yeah,
and forth. So we're like, no, 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 we're doing these adjustments before you go back up north. Like,
yeah.
so we'll fit you in every 3 days if you need to, in order to do that.
Yep, we're just the opposite. I mean, we have the
Yeah.
opposite snowbirds, but yeah, same thing. They're
Yeah.
like, can we get this done and over with, by next week? And that's not how it works. Sure, we'd
Yeah.
love to do that, but no, we
Yeah.
can't squeeze them closer together. We can
Yep.
always extend them out. If
Hmm.
you can go down to Florida, come back in a month, that's fine. We can
Yeah,
use
that's fine. Totally fine.
your glasses. But that's always, not a problem. So for patients, naturally, like we just talked about, these patients tend to be kind of type A. For the patients who just keep wanting more and more reading, how do you counsel them? That was a question that just came through. How do you counsel them on the limits of physics, right?
Hmm.
The laws that exist about near vision and
Yeah.
compromise to the distance. How do you have that conversation?
So I'll kind of answer this one, Foz, because like doing your
Yeah.
own adjustments as the ophthalmologist, I see this all the time, and I'm very lucky to do all my adjustments because I'm setting the expectation to them every time we do an adjustment, not just at the consult before surgery. So, everybody thinks that this lens is adjustable, right? We could do anything with it. There's
Mhm.
no limits to adjustability. There are limits to this lens, just like any other multifocal lens we use, monofocal, any toric lens we use. There are limits to this to this technology. Okay, when I go in there and I see a patient who's 20/20 and they're J1 and they're reading their cell phone when I walk in the room, okay, and they want more reading, but if I give them more reading, I'm going to drop their distance vision quite a bit. I tell them, hey, look, if you're my mom, you're my dad, you just read your cell phone for the last hour in the waiting room, we're done. Like there are limits to this. I'm pretty brutally honest with the patient, just kind of like how I am here. It's like,
Mhm.
hey man, you're doing great. You're seeing everything I want you to see. My expectation for you was J2, J1 reading vision. Okay. And you're doing that. We're done. If I push you any further, I could fall off a cliff. I can make it worse. So I just kind of give them that fear component to them a little bit, and say like, if they're like, oh, I used to be, I'm reading out here and I want to be up here, it's like, no, no, up here is not normal. This is normal. You were a -6 before surgery. Now you're like a -125. Okay. So they got to use that hand placement a little bit too. So I kind of just be really realistic with them and like say, hey, there's limits to this. And if I continue to do this, I can do that. But you're leading me down a position. I've done so many of these. I see when there's a problem, it's because we go too far. Okay. And I think that's not reinstated enough at the consult before surgery, that there are limits to this technology, and J2, J1 phone reading is the limit you should be expressing to this patient. Now, if you're a book reader, 8 hours, 10 hours a day, you're going to like a little magnification, a little bit of cheaters. I would like that if I'm studying for a test or I'm reading, a good book, Game of Thrones for 10 hours a day. Okay. So I say, hey, this is for distance, computer, and this is for phone vision. That's the expectation we set.
How do you do it, Eric? How's that conversation go
Well,
for
I
you?
mean, I think this brings up two really important things. Number one, Brian hits it on the head. He is a master communicator. I mean, I'm not trying to give this guy a big head, but he is. And Dr. Newsom is too. I'm blessed to work with these guys because they're just good communicators. And setting expectations is important when you're selling anything, whether it's LASIK, ICL, RX site, it really doesn't matter. You have to set expectations, and they do a great job at it. Like Brian is like, he'll give them real life examples like cell phones and all that, and he'll show them in the room, and then he's reinforcing it. So it's like, it's really easy. When I'm doing most of the work, that's got to be me. That's got to be me. So you've got to sit there and really talk to your patient a lot and reinforce because they're always bargaining with you. You got that type A person, you got that CEO, you got that A-list actor, and he's pushing you, he's pushing you, he's pushing you, or she is. So in those patients, you're gonna have them. Nick, I know you've had them.
Oh yeah. No, all my
You
patients
got
are happy and they're totally
you
reasonable.
got to, yeah, of course. You got to stop.
Yeah, come to
And I would
Wisconsin.
say, okay, guess what we're doing? We're going to put a contact lens on your eye today. Dr. Szabo may not do that, but I will. I'm the OD, and like, here we go, and we simulate that crap, and that's very important. And then when they either buy it or they don't, and that's usually when you push that disparity over. And sometimes I'll put a strong one on there because I know they should be done. And I'm like, oh, here's a +1. You really probably a +15. You might like it, and give me this. Here's a +1, and they're like, no, this sucks. I don't like this disparity. Every once in a while, you'll get one that buys it, and then your confidence is going to go up to maybe push for a higher disparity. I mean, all in all, I think our enhancement rate, I mean, Brian, you can sound off on this, for the amount that we do is crazy low because we do a good job counseling, talking to patients, setting expectations, moving in one direction, demonstrating trial lenses and contact lenses. I mean, that's kind of the process. And you got to stick to it, guys. That is very important that you and your surgeon are like this. Like me and Brian talk more to each other than we talk to our own wives. I mean, they get like pissed at us
Yeah.
because we're talking like every day. But it's important. We love it. We dig into it. We're always talking, and I'm lucky. I know that's not always possible for everyone here in this call, but do it as much as you can. If the more you're communicating, the better results you're gonna have.
Yeah, man. I think brutal honesty is really important, and it
Yes.
I think the people who have success with this, because Brian, the way you put it is totally how I do it. We talk about what the limit is, and the limit is there are laws of physics. I've said that a million times. There's laws of physics that I'm not in control of. I didn't write them. I didn't come up with them, but they exist. I would love to get you the best of the distance and the reading and no compromise. I would love to make that happen, but I can't. We don't have that option. So what we're going to do is a little bit of finessing in some art to try to cut the corners a little bit. So especially after our first adjustment, I give my patients three direct pieces of homework. Number one, I don't want them to use their reading glasses because typically we're going to start a blend. And we usually do it depending on an LAL plus or an LAL, it's going to be between -50 and -75 with a non-dominant eye.
Yep.
I tell them, don't use reading glasses. You might need them, and that's okay to pick them up if you absolutely need them, but really resist the urge to pick them up because the quicker you pick up your reading glasses, you're going to realize that things are magnified, right? And the brain just likes a magnified image. And you're going to get used to that, and you're going to delay that neural adaptation process, which can take up to a few months. And so we want to get that process started. Number two, don't compare the two eyes. Don't do this. I hate it when they do this. We call it the refractive salute. I'll walk into a room and
Yeah.
patients doing
A
this.
salute. I
Yeah.
hate
Why are you
that.
doing that?
Well, they're
Don't
doing,
do
they're closing. Like, do you ever do
Yeah.
that before surgery, Nick? Why are we doing that now?
why are we doing that? It's like
Yeah.
asking me to throw a baseball with my left hand. It's going to look awful, right? I'm a righty, but
Yep.
I don't notice that my hands are different unless I isolate them. So don't isolate your two eyes because we are intentionally making them different and we're trying to trick your brain. Don't tell your brain we're trying to trick it. And then number three, use teardrops. We always want our patients on a
Yeah.
good brand of preservative-free tears routinely because remember that UV light is intense and that it is going to make a little bit of a disruption to the cornea.
Sure.
And that can impact things. That's the difference from 2015 -1 to 2020 +2. Those two letters,
Mhm.
which are like the end of the world to some of our patients, that's
Right.
tear film. So we always want them to maintain that. But it's brutal honesty. And I
Yeah.
think that communication is so important. And it's important between you and the patient, whoever's doing the adjustment, and then surgeon to OD, and then OD surgeon to the referral network to make sure
You
that
just hit on
everybody.
a big thing though, not just with LAL, but LAL plus or whatever. Um, the dry eye thing,
Yeah.
that's also going to happen, and you
Mhm.
got to be very cognitive of that. Like when you have refractions that make sense, like when I talk to other players and with ourselves, with Eric Weinberg, in the operations, and probably the biggest thing that he sees out there when things go wrong is when there's a refraction that doesn't make sense
Mhm.
and you chase it. You're just doing it to do it. And you didn't look at the surface maybe enough or didn't treat that dry eye, and you're going to end up in a world of hurt quick. So, my advice, and we do this all the time now, though we learn from some mistakes, of course. We got some volume, so, we've got that luxury, is slow down. And if that surface looks weird, you may need to pump your brakes for another 3 days and treat that, do some plugs, or I do a lot of dry eye. I have IPL, serum tears, plugs. That's part of my clinic pro cares. It's just part of what I do, which is important to do at least something. And some of that, you don't have to necessarily be a dry eye expert, but you got to do some of that surface management. and then kick that out for another refraction another day. Live to die another day. Another small thing is just the that those RK patients, and I know that's not what this is about, but be careful with
Mhm.
those. Make sure
Yeah.
those are in your afternoons. Don't be refracting those at 8 a.m., people. You will end up in trouble.
Yeah.
And the
Oh,
other
yeah.
thing
Try to
I
get those
like,
on the same time
yeah,
every day.
Yes.
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 And the other thing I kind of want to touch on, because you guys are bringing up great points about variables, right? How do
Mhm.
we eliminate all the variables before we do an adjustment? So the other thing I want to talk about is an early YAG. Okay.
Oh,
There
yeah.
are so many of my surgeon colleagues that I do calls with, and hey, this patient didn't have where they want to be, or hey, I'm having a problem. And one of my first questions always is like, have you yagged it yet? And they're like, well, no. And I'm like, why are we so afraid to yag these patients? You want to get rid of the variables while you're doing adjustments. So hell, if they scar a little early, I'm taking them right downstairs and I'm doing the yag. Okay. And I'm taking that variable away. I'm giving them some time away. I'm gonna have them come back and we're gonna start adjusting again. And the reason most of the surgeons will tell me I haven't yagged, they say because I'm thinking about taking it out. And most of the time it's after locks. And I'm
Mhm.
like, guys, have you guys ever took one of these lenses out after you've locked it in? It
Mm.
literally becomes like a piece of glass.
Yeah.
It's very difficult to cut. And then you also, it's not like cutting out a different type of, like a hydrophobic acrylic or, any of that stuff. It is like glass. So when you cut it, it literally shreds in the eye. So you got to really be careful and make sure you get all the pieces out as well. So I tell it like you're not taking this lens out. Okay. You're gonna probably be yagging it a little earlier. It's okay to yag it. And worst comes to worst, if you're a refractive surgeon and you have somebody that can do LASIK or PRK, worst comes to worst, you're doing a little bit of a late enhancement, we call it. It's not the end of the world. Okay. So I would just say earlier, get the variables out, like Nick, what you're saying. Dry
Mhm.
eye, pause what you're saying, dry eye, and yag is what I would say to do too.
Yeah. Quick detailed dive into the YAG. What I was noticing with some of the high energy legs, because we do them early, there was an occasional crisscross kind of phenomena that was occurring. And I was talking to my rep and some of the other guys that I've known since the beginning and through the studies. Keep the energy low on those
Mhm.
legs. Brian already knows this. To not disrupt those macromers, because you can get some weird, like kind of like crisscross Maddox rod effects from that. That is something that can happen with this lens. So that's one thing. And again, yeah, don't be afraid of it because, 33% of effective, lens positions produce refractive errors, right? So if you do have a YAG later and that lens moves a little, remember it's kind of thick and
Mhm.
that thing vaults a little anterior or posteriorly, you're just introducing error you can no longer adjust. So the cool thing about doing a YAG early in the process, which people forget about, you can adjust to any small effective lens position change that just occurred. And I see that all the time.
Yep.
All the
That's a good point. With the YAG, one last thing. You do a circle pattern. The lens is easy to pit, like you mentioned. If you use
It
a,
Yes,
is.
yeah, it is easy to pit. It's the silicone nature of it. So you would want to use a circle or an omega. You wouldn't want to do a cruciate
yes,
because then you could pit the center part of the optic. I've seen
correct.
that done before too.
Yeah.
Not by my surgeon, but outside. And at that point, that lens is hard to get out, especially with an open capsule. Good
Oh
luck.
yeah.
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 Yeah, yeah. So
Yeah.
Better know how to use a excimer a little bit after you do
yeah.
it. Yeah. So that's all. That's all.
So let's get to some of the questions too. So we had
Yeah.
one
Good.
question about, let's say a patient had an LAL in the non-dominant eye. What would you do with the dominant as the second surgery? Would you put an LAL plus in the non-dominant or in the dominant eye in that case?
Yeah. So it all depends on what the expectation was at the consult, right?
Mhm.
And what the topos look like. Are they post refractive? All that good stuff. So a lot of it goes into it, and we're looking at all this before we make our patient selection. So say, I would go back and look and just see where we're at before picking an LAL or an LAL plus for that second eye. And I would just see where the patient was at, kind of like where we wanted to be with our expectation and well our measurements look like before deciding on that second lens.
What about you, Eric? Any thoughts?
LEL. I don't think I'm going to mix match that way.
I don't think I would either.
Yeah.
Honestly, when I think about it, I don't. Yeah, I think having the optics the same, especially if you're going for a
Yes.
distance eye, I would just stick with an LAL. I don't think there's any advantage to doing an LAL plus in that case.
Yes.
Okay. How about this? So, patient with a really high near demand. Have you ever done a bilateral myopic target? And would you use an LAL plus, LAL, mix and match?
So this just happened to me. It was a lady, very particular lady.
Mhm.
She designs airport blueprints. So she designs the airport lounges and the mechanisms people use to walk around. So she's looking at blueprints all freaking day long. Okay. So the other problem was she had bilateral epiretinal membranes. Okay.
Okay.
So, we initially said, I know you want reading. Let me get you distance first. Let me get you distance in one eye and the other eye, a little bit more reading. And let's just kind of go from there and see. Okay. And of course, she wanted both eyes near. So we did, she started out as like a minus maybe like 150 before surgery,
Mhm.
bilateral ERMs. We put LAL regulars in both eyes because of the ERMs. Okay. And then eventually we got her to like a minus 150 in both eyes and she loved it because she didn't mind wearing glasses in the distance. So it was the strangest thing I've ever been a part of in terms of the LAL because she was so particular and there was some variables there I didn't really like. It'd be a lot better if it was just a normal, perfect eye. But those ERMs really threw me off. If those ERMs weren't there, I don't know if I would have chosen LAL. You know what I mean? So
Mhm.
for that bilateral reading that she really, really wanted. But we got her at minus 150 and she's happy as a clam in both eyes. Loving it.
Yeah, so we've had a couple patients like this where they've done bilateral myopic, and the cool part about this is that they can change their mind. They go into this thinking
Exactly.
that I want distance, and then they realize, actually, maybe somebody who's a little bit older, they do a lot of reading,
Yep.
they're not really active, and actually, most of my life is up close. So what I typically will do, if I knew that beforehand, I'd go with an LAL plus, so you could
Mhm.
Yeah.
potentially surprise them with the amount of distance that they could achieve without glasses on.
What if they had bilateral ERMs?
I would do just LAL in
Oh,
that
yeah,
case.
good, good.
Yeah,
Okay,
yeah, I
good.
would do
We did
LAL
it
in that
right.
case. So, assuming it's a normal healthy eye.
Yes,
So
yes.
for instance, this one guy I remember he was really into Legos. That was his hobby, just a big time Lego guy. And that's all he did. He was up close. And he was a minus like 6 before,
Yep.
so he was a high myope. And we did bilateral LAL pluses. He was a healthy dude, no problems with his eyes. We ended up staggering him a little bit, so I ended up leaving his dominant eye, I think about minus 75, and then his non-dominant eye 1 1/4-ish. And so that
Okay.
gave him enough depth of focus. He was very, very happy.
Yep.
And binocularly, he was 2025 like plus at distance. And he
Hmm.
was very he went into this thinking that for sure I'm gonna need glasses. I know I'm gonna need glasses to drive. I'm totally cool with it. And we ended up locking him in kind of before I thought we were gonna be done. And he's like,
Yep.
actually, this is awesome. I love it. He could do everything he wanted to. I did give him a pair of glasses, but he didn't wear them. I saw him, for his post-op, he didn't have glasses on. He was totally fine with everything.
Hmm.
So that gives you the flexibility, which is really, really cool. So I don't shy away from a bilateral myopic treatment. I
Yeah.
do warn them and I, make sure that
Yes.
they're properly educated. And I'm
Big time.
brutally honest with them that, hey, you might need glasses to pass your driver's test. That might happen,
Right.
depending on what your goals are, but we can do this. And
Hmm.
usually I would stagger them just to try to give them a little bit more depth of
Yep.
focus.
And I'm sure, Nick, you started out with them being distance targets, right?
For
And
sure.
then you kind of worked your way down. So always, regardless of what the patient wants, we're starting them plano to a little bit of hyperopic, when we pick the
Mhm.
lens for surgery. And then we work our way from a little bit of a hyperopic to a myopic correction, always going down that hill.
Do you guys always surgically target plano with both eyes, no matter what lens it is?
If not a little bit of hyper up, right, Foz? When we're picking lenses out.
Yeah, we played with that a bit. We ended up back at a little bit of hyperopia. It just
Yep.
gives us the best optical results, in at least in our experience.
Same with us. Yeah, we don't get too cute with,
No,
myopic targets. We'd
no.
rather be a little
We
bit
don't
on
do
the
that.
plus side. It serves a couple purposes. Number one, you're moving in the myopic direction, so you can kind of more equally control the macromers to move in that direction. But
Yep.
it does give the patients at least a sense of what they have. We're always prioritizing distance when we talk about this for most patients, and so they
Yeah.
understand what the distance is. Then you give them the ability. So there's a psychological side of this too, the ad. You get them the
Yeah.
ability to read so that every step of the way they actually see the magic.
Yep.
It's kind of part of the sales component of this, I think. But
Yeah.
we
Right.
found, I mean, we've never really gotten too cute with mixing and matching the target,
Mhm.
whether or not we mix and match.
And Nick, that brings up a good point too. So I know Mitch Jackson and Hunter talk to me about this all the time, where you kind of like to give them a little hyperopia so the lens isn't just quite perfect before your first adjustment, and you get
Yeah.
that wow factor,
all the time.
with
Yep.
that patient on the first adjustment. And that's why I walk in the room for the patient's first adjustment. I'm like, yeah, you're seeing okay now, but this is where the magic happens right here. Okay.
Mhm.
Yeah, your surgery went great. We knew it was going to go great. Okay. This is where the magic happens on this first adjustment. And then tomorrow in 24 hours, when it kicks in, you're going to be like, holy shit, there it is. Okay.
Yeah.
And then we're going to
Yeah.
play with it from there.
I always get annoyed when they come in when I walk in and they're like Plano because that
Yeah.
happens sometimes.
Yeah.
Like,
It
dang it,
does.
like
It
Luke,
does.
Tough
Luke,
one.
you're stealing my thunder, man. Like this is I need so,
Exactly. Exactly.
yeah. So another question that just came in: patients with high SIL, like 3 diopters of corneal
Yep.
cylinder, how do you select their spherical equivalent?
So I was going to hit on that before. So that's the only time that I will actually change my targeting a little bit. So in those cases, when you have like an RK patient, and we've actually presented an RK success story at every academy since the LAL was approved, actually, which is pretty cool with one of my residents. And we just actually presented one this past weekend at Drexel at the residency day up there, which is pretty wild. So this lens kicks ass actually in RK patients. If you really
Yeah.
know how to use it, it really just kicks ass. It's actually unbelievable the visions they can get. But if you just even have a straight up high cell, forget the RK, you got to be careful. You have to try to best for those patients as close to plano as possible. You want to be using all that energy for the cell. You
Mhm.
really do to get it. And we've
Do
done some
you
crazy ones. The one that we presented was 4.5 on the first refraction, and they got the Plano. So
do you guys ever do arcuates or
we
LRIs?
don't. So that is something I had a good talk with your COO about.
Okay.
We're not a big LRI fans. We did it back in the day. We're not big fans of that. He's talking about some exciting things I don't think I'll talk about here. But that's not something we've had to do, and we've done some pretty crazy cases.
Hmm.
And we just kind of gotten lucky on a lot of these. Um, like with RK, that's out anyway. But even
Yeah.
on a Virgin Eye, we don't tend to do that. LIs don't tend to be that stable as people think. And I've got many decades of experience with them actually. They can change, and that's not a good thing when you're looking for precision, at least in my experience. So,
And that brings up another point, in terms of if there is, you have that big patient with that big astigmatism and you're pushing like plus 350 or like a plus 4, the limits kind of the tech, you always have a late enhancement with you.
yeah,
Okay. In the bag.
yeah,
If that's why, this lens, yes, it's adjustable. Yes, it cuts down on your IOL enhancements greatly, like significantly more than any other kind of lens. But there are times when, hey, there's a little residual SIL because this patient's eye was very football shaped, okay, to begin with. And we could just do as much as you can with the LAL and we'll do the rest on the cornea, which
Yeah.
isn't a big issue. So we're more so that way than we are
yeah,
LRIs if we have residual.
yep,
Yeah, so we don't have a LASIK suite in-house, so we would have to go out of the clinic. So financially, that's not easy for us. So we do
yeah,
LRIs, we do AKs with a femto,
Sure.
and we try to debulk it. We don't try to eliminate it. So let's say we have a
Yeah.
patient with 3.5 diopters of corneal astigmatism, especially if it's like oblique or something like that.
Mhm.
If we can get that cylinder down to a more workable range, you're going to reserve yourself more macromers. So if you do have a
Sure.
refractive miss and you gotta move spherically, or if you want to get down a little bit further myopically, you got more wiggle room. Now, for those patients, I typically would wait at least another week or two, and I kind of want an extra
Yes.
refraction to make sure that things are stable.
I
Big
was just
time.
going to ask you what your timing is there, Nick.
I
So,
usually give it at least
yeah,
another, usually about 2 weeks.
okay,
And
Okay.
I'll get another refraction. I'll bring them in for their first scheduled treatment, which is always 3 weeks post-op. And I'll do just a refraction. I have no intent to treat them. And then I'll
right,
usually kick it out another 2 weeks just to make sure they're
gotcha.
stable.
Just to make sure they're stable.
Every
Yeah,
cornea
makes
is
sense.
different and also depends on, a lot. It depends on a lot of things. It depends on how big the arcuates are, where they're at,
Mhm.
how thick their
Yeah,
cornea is. Was it a manual versus was it a femto? We almost always use femtos now.
right,
Mhm.
But as long as it's stable, then I have no problem. But if you
Right.
can work in one meridian, if you go back to your school days and you look at your power crosses, if you can focus with one meridian, you can be a little bit more accurate, at least theoretically. And so I try to do that, like you said, Eric, working in the one
yeah,
meridian, trying to get that cylinder, and
yes,
then you can focus your macromers working in the myopic direction. But
Big time.
Yes.
Don't forget the advantage of having a little bit of astigmatism. If it's exactly with the rule, that's not a problem. You know, you're going to have depth of focus naturally that way. So that's an old refractive trick that, you know,
Yep.
you still
Yep.
have.
hmm
What about going back to YAGs? So when you do a YAG, this is a
Yes.
question that came in. How long do you wait until you do an adjustment after your YAG?
Usually, if there's not a time constraint, a week. We give it a full week to kind
Okay.
of heal in. And sometimes the YAG puts them in a position where they want to be and they're happy. You know what I mean? So I do know sometimes if a patient's in a rush, you can do a YAG and wait 3 days, okay, to do an adjustment. But generally, at our practice at New Samai, we do a YAG and wait a week and come back if
Yep.
if time allows.
That's what we do too. Yeah, we're
Yep.
about a week or so,
Yep.
you know, after the YAG. Let's see. Any other questions that do you YAG? So you YAG before the post-op. How do you bill for that? Do you bill for it?
We
We
do
don't.
not.
Part of
We
the
don't.
package. Yeah.
Part of the package.
Yep. Yep.
Part
Same
of the
with us.
package. And we do
Yeah.
bilaterals. So we
Yeah, we do
usually
about same day bilateral.
do them
Yep.
same day bilateral.
And don't
Nice.
even mess around. If you see PCO in one eye, just take care of it in the other eye.
Yeah,
You
just do
know,
them both.
don't have the patient come back for a YAG, do an adjustment, have to come back and do another YAG. You know, just take care of that premium patient.
Yeah, build that into your pricing model, I think. You know, it's a part of it, almost unexpected. Just build it in. You know, if we don't do a YAG before the treatments are done, there's a good chance that we'll do one shortly after.
Yeah.
Hopefully don't get any, you know, any lens movement at that point. But
Right.
yeah, just build it into your pricing model.
Yep.
Probably got one more time for one more question. So when you decide to activate the spherical aberration for patients, whether it's for LAL or LAL plus, or even with mixed, do you, well, I think the question is asking, do you do it with the LAL or the LAL plus? I guess there's a
So
pretty simple question, pretty simple answer to this one.
say it one more time, Nick.
So do you decide to induce the spherical aberration for the LAL or the LAL plus? How do you decide when to induce it?
So with the LAL, usually we are in like if we're playing on a near target, we are going to induce that negative SA into a
Mhm.
regular LAL. Okay. With the LAL plus, though, our first adjustment, we are not giving that negative SA. I don't think the LAL plus
You can't.
doesn't deliver
You
the
can't
negative SA
anymore. You
to it.
used to be
can't.
able to.
Yeah.
They turned that off.
Yeah, they
Yep.
turned that
Turn
totally
that
off
off.
on the
They
plus
turned it
model,
off.
not on the regular.
Right.
Yeah.
With the
So
exception of post-refractive, Brian, don't forget.
yes,
The
yes,
exception of
yes.
post-refractive.
So yeah,
Yeah.
so on the LAL plus, there is no more negative SA.
Yes, but you don't deliver the SA in the post-refractive patient ever.
Yep. Yep. Exactly.
Yep.
Don't do that.
That's what we do. I mean, we do the LAL. LAL plus, you can't do it. It's not a part
Yep.
of the nomogram
Right.
anymore.
Right.
The LAL, we do it in eyes that are healthy. If it's a post-refractive eye, I probably wouldn't do it.
Yep. Yep.
Well, awesome, guys. Hey, thanks for all your insights. Thanks for the chat. Appreciate you guys sharing your data. The data is pretty impressive. That's super cool stuff, man.
Thank you. Thank you, guys.
Thank
Thank
you
you.
everybody for joining. Keep an eye on your email. We'll do another one of these next month, and I'll have the recording up on the peer-to-peer.academy website shortly if you want to look it over.
Thank you,
Awesome.
everyone.
Thanks so much, man. Great talking with you guys.
Thank you,
Appreciate it.
Nick.
Thanks
You're
for
great,
joining
man.
us. We'll see you.
All
See
right,
ya.
guys.